I'm Pam Jackson with Sonora Quest Laboratories. I'm a population health manager, and I'm proud to introduce our next session. Sonora Quest is a proud gold sponsor of the 15th Annual Arizona HIE Summit and Trade Show. As a leader in the diagnostic information business and proud partner to our HIE since its inception, Sonora Quest delivers millions of laboratory results every year that are vital to our partners and patients that we serve. Sonora Quest offers a suite of proprietary population health solutions, including enhanced data delivery analytics, analytics through our Actionable Insights Management platform, and custom patient outreach solutions. Our dedicated team provides near real-time data and insights to help close gaps in care, identify risks within patient populations, and track individual patients facing chronic conditions, leveraging our laboratory testing expertise and vast data repository for patients throughout Arizona. And now, I'm thrilled to have the opportunity to introduce our moderator for our next session, Jami Snyder. Jami Snyder serves as the Director of Access, overseeing Arizona's Medicaid and CHIP programs. She was appointed by Governor Doug Ducey in 2019 after having served as the agency's Deputy Director. With more than 20 years of experience in public and private sectors in the health and human services industries, Ms. Snyder's expertise includes regulatory oversight, policymaking, and leadership development. Prior to joining Access, Ms. Snyder served as the Medicaid Director for the state of Texas. She is the previous president of the National Association of Medicaid Directors and holds a master's degree in political science from Arizona State University. She also has her bachelor's degree in political science. And as of this morning, she is the recipient of the 2022 HIE Excellence Leadership Award. Let's all welcome Jami Snyder and her panel.
Thanks so much. Well, I am thrilled to be here this afternoon. We have a fantastic panel. Our focus this afternoon is going to be on CommunityCares, a closed-loop referral platform that we are working in partnership to stand up. Just to give a little bit of background before I introduce our panelists. Again, I'm with Access, and over the last decade, really, Access has been focused on what I like to call our integration journey. And that journey up until November of 2019 was focused primarily on integrating the provision of physical and behavioral health services. But what we knew is that we really needed to extend our understanding of what integrated care looks like. So in November of 2019, we launched our whole person care effort, where we really put that stake in the ground saying that integrated care from a Medicaid agency's perspective needs to be about the integration of physical health care, behavioral health care, and connecting individuals that we serve to needed social service supports. And so initially, when we launched the Whole Person Care Initiative in November of 2019, before the pandemic, seems like a decade ago at this point, we really talked about a series of programmatic initiatives that aligned with some work that we had done historically. Doing some work in the housing arena, we receive a pretty generous state appropriation every year to provide rental subsidies to about 2,500 members that we serve, so looking at how we could extend or expand our work in that area, looking at addressing the issue of social isolation, which again, November 2019, seemed to be an issue we needed to focus on. We now know that concerns around social isolation are paramount. Looking at work that we could do in the employment arena to connect those that are enrolled with Medicaid to employment opportunities and vocational rehabilitation services, and looking at how we could extend our work in the transportation arena, understanding that transportation can often be that one barrier to care and to accessing needed social service supports. But as we started to have a conversation about our work in the social determinants or whole person care arena, it became pretty evident pretty quickly that we needed to build a foundation under our work around social determinants of health. And in particular, we needed to make it easier for clinicians and community-based organizations to connect individuals to needed social supports in their communities. So that's when we started having a conversation, like other states, like North Carolina and California and others, about the need to establish a closed-loop referral system, which at its very sort of basic, sense is a technological platform that makes it easier, again, for clinicians and community-based organizations using the platform when they identify a social service need in the midst of a visit with a member or with a patient to simply click on that need within the platform. The platform then connects to a referral database that identifies resources in that individual's community, and assuming that individual or that patient has provided permission, it connects that social service resource in their neighborhood. It connects them directly to that resource, so that resource can reach out and say, we understand that you may have a need for a food box. We'd like to provide that to you. And then we can see through the system that we actually close the loop, that they receive that resource. And so again, I think as we had conversation following the launch of our program in November of 2019 around what we needed to sort of get the ball rolling, we really thought that foundation around the closed loop referral system, now in Arizona known as CommunityCares, was absolutely essential to our work in this space. And so I am very fortunate today to have 3 subject matter experts with me that can speak better than I ever could about the value of closed loop referral platforms and speak to what we're doing in Arizona. I'll start with Taylor Justice. He's the CEO of Unite Us. Unite Us is the platform that we're using in Arizona to stand up our closed loop referral system, CommunityCares. Also, Shawn Pearson, the CEO of the Zion Institute. She's going to provide us with some invaluable firsthand insight into what it looks like to use the platform that we're standing up currently in Arizona. And Andrew Terech, the CEO of the Director of Social Determinants of Health and Work, excuse me, Melissa, the Director of our Social Determinants of Health and Work at Contexture, is going to talk a little bit about what we're doing as a system to really establish a sound platform, ensure that community-based organizations as well as Medicaid-enrolled providers are able to effectively engage with the platform, and what the future looks like in terms of our work around social determinants of health and our community care system more specifically. So each of our panelists are going to provide a brief presentation, and then we'll wrap up with some questions here, and then finally with questions from the audience. So at this point, I'm going to turn it over to Taylor to get us started in talking about Unite Us.
Thank you, Jami. So again, my name's Taylor Justice from Unite Us, and I think Dana on the previous panel stole a little bit of my thunder here, but what we wanted to set out to solve originally was we saw a disconnect with how people were connected to organizations in their community. Navigating a sea of goodwill of a bunch of different organizations across a bunch of different service categories was often left, that burden was often left on the individual in need to navigate. In organizations that were making referrals to complementary services in their community often didn't have the peace of mind when they send somebody out their doors. Did they actually get the care that they needed? Were they able to show up? Were they eligible for those services? And if they didn't receive those services, what are they doing now? And so we set out to kind of solve the resource directory only problem. Not to say that resource directories aren't important, they are. But if that's the only mechanism that we're doing and we're highlighting and really focusing only on the referral, we're kind of only going halfway. And so what we set out to do is establish engaged networks that really prioritize community-based organizations. And so no offense to my healthcare partners in the room, my plans and my systems, but sometimes you get over-prioritized. And if we're actually going to address social determinants of health, you need to prioritize those community-based organizations that are actually doing the work. And so in order to build a network, you have to have boots on the ground. Just like if I go into a health system and they want me to do an integration with an electronic health record, or a plan that wants me to do an integration with a care management platform, you have to have that same level of support for community-based organizations who are historically understaffed, underfunded, overworked, but have a lot of burden of taking care of their local communities. And so when we talk about building an engaged network, think of your traditional clinical care coordination network, but extend it now into the community. So organizations that provide food and transportation and housing. And those aren't just your big service categories. That could be a small mom and pop organization that obviously might not have the capacity today to service a large population, but they're so vital and critical to their community. could be a faith-based organization that only has a food pantry for a couple hours a week. That's a resource that someone can access that is really critical to them, but sometimes gets deprioritized. So when we build community-wide care coordination networks, and especially with the network here in Arizona, it's bringing those three sectors, healthcare, government, and community, to the table where everyone's operating within the same ecosystem, and everybody can securely exchange data around shared clients or families that they serve. So when we look at the traditional referral, and I won't necessarily read this to you, but again, we want to solve the issue of the burden being on the individual in need, and rather them having to work their network, why doesn't the network work for them? And so when you create an ecosystem that connects all these nodes together, you have a better way of tracking, did they show up, did they receive those services, but more importantly, it's going to show you the good, bad, and the ugly. What's working so that we can double down on that, but more importantly, where are the gaps? Where are the issues why people might not be able to participate? Are they running into capacity issues? Are they have very stringent eligibility requirements and people are making referrals there because they don't know? It creates a mechanism for the invisible to become visible because you're connecting all the dots and you're just laying that foundation that Jami mentioned to ensure that we can start to optimize how quickly should it take someone to receive food or transportation or housing, knowing that we're going to uncover a lot of things that aren't really easy fixes at times. But it gives us a starting point with CommunityCares here where we're laying that foundation across Arizona so that, again, everyone has access to the resources that are available to them, but then they also don't have to continue to do the manual work of following up with everyone. They can send a referral through the platform, and they get an update if that organization accepted, and they get updates along the way as they're receiving those services. So a little bit about Unite Us. We've been around for about a decade. We initially started just in the veteran and military space, but we're about 1,000 teammates strong. We operate in about 47 states across the country, be in every county, every parish across the nation by the end of this year. And we went and set out on a growth strategy in 2021, and we combined forces with NowPow. I'm sure that's a name that is familiar for most in the room, but through that acquisition of us coming together, 70% of SDOH infrastructure across the US, or dollars going into that infrastructure, right across this network that Arizona now has, is rolling out and deploying. And so the beauty of this relationship is it marries two organizations that initially were in the same arena, but we're focusing on slightly different things, both critically important to kind of an end-to-end solution. Whereas NowPow was born out of the University of Chicago, has great ties with electronic health records and making sure that we can do screenings at scale. Where Unite Us picked up is building those relationships with community-based organizations, and when you combine those efforts, you now have the ability to really address needs at scale in an effective way. So by joining our forces and supporting the CommunityCares network, we have the ability now and the opportunity to make significant change and to ensure that people's needs are addressed in a timely manner and in the right cadence. So the closed-loop referral system, as you see here, is again, a tool. This is not a silver bullet. This is a tool that put into the hands of organizations that do this work every single day to not have to manually go on Google and make a search for a resource, or to go through that binder of resources that you might have in at your organization. And again, have that peace of mind that when I send somebody out into this network, it's an accountable system. I know that someone on the other end is going to respond, and then I know at the end of the day, were they taken care of? And then you can start to step people out of whatever predicament that they're in, be it in crisis or just needing to connect to a critical service for a short period of time. But now we don't have to have an infrastructure or a system that is kind of make a referral and hope it works out. So at the end of the day, the big focus here is in Arizona having one network, CommunityCares, and the beauty of the partnership between Unite Us, Contexture, and Access is that the vision is you create a mechanism where however individuals want to connect into this network, however they engage with their community, be it through healthcare, be it with government, or be it through a community-based organization, have access to a broader system. And so we're super excited to be here and explain a little bit more later.
And I think one of the exciting things for us as an agency with the CommunityCares platform is that ultimately it's going to allow us, right, to take a look at those individuals that are enrolled with the Medicaid program that actually connected to services and supports that they need, and look at it from a health outcome standpoint, whether it made a difference in terms of improving health outcomes. So there's some real system level analysis that I think we're really excited about. I think one of the, as Taylor mentioned, I think one of the real benefits that Unite Us brings to the table is they're really connected to community-based organizations, prioritizing CBOs and the role that they play in connecting folks to care. And so we are so lucky to have Shawn Pearson with us today to talk a little bit about her firsthand experience in using the Unite Us platform.
Thank you for having me, first of all. I want to applaud the marriage because I've been on both sides of this relationship in terms of being a community-based agency that did not do healthcare and now becoming a community-based agency that focused on social services for more than a decade, and now being in the health arena with an integrated clinic on our campus.
That's great.
Understanding the complexities of the marriage and how difficult it is to be able to connect an individual who needs the help with all of the services beyond the food box, or beyond the prayer for the faith partner, or beyond whatever that single resource is in the health industry. Maybe they saw the primary care physician, but they don't know how to access something for their light bill or for their rent, or for something that their children need. And so being able to be a part of Unite Us for more than a year now was very exciting for Zion because of that 10-year journey we had, not having the ability and not having the resources as a smaller community-based agency to connect all of the dots that we knew individuals needed. So Zion started almost 20 years ago doing this work, and the last 10 years has been focused in South Phoenix in particular with the primary work that we are doing with social services first, and then healthcare over the last 2 years. But what we found was that major disconnect created all of these silos where everyone that we served only went so far with their service. And so through the introduction of Unite Us and the team that we've been able to work with, it instantly provided a level of communication that we did not have. Even though we had multiple partners as the Zion Institute, there were probably more than 300 partners collectively over 10 years that we had, but we still lacked the capacity to connect the dots for all of these families unless we literally walk them from our door to the next, because it was just a phone call, and then hoping that that referral happened. But through working with the Unite Us platform, we've been able to connect to a partner, actually build their capacity, leveraging ours with theirs, and creating that continuum of care that's actually sustainable. So I'm excited to see that both sides of our world is being married. So our health-based work that we do with the integrated clinic, behavioral and primary care, is now married to the social services. So it creates that no wrong door opportunity for all of our folks. So this slide just gives a snapshot of all of the sectors that we're in and all of the different partners and work that we do on the campus. But even with all of this and all of these connections, without a platform, without a tool that we could actually use to make it easier for us to connect our partners, it was still a limit to how much we could do within that ecosystem. So seeing this marriage is exciting for me. So I'll be excited to see what the relationship turns into, because you're giving voice to a lot of partners, like you said, a lot of passion, but no capacity to really do the work that we wanted to do with our missions. And so this opens the door and gives that opportunity for us to share the information that we need that is critical, and also share information that's been shared with us that healthcare providers may not have for those families, because healthcare is not always the space where there is trust for the communities that we serve, communities of color in particular. And so just making sure that we can be a voice and an avenue to make the connection is really huge for us. And so I'm excited to add all of the partners that are coming on board that will be a part of this. Our plan is to go tell it on the mountain for everybody else that has been waiting for a solution, and have them be part of this whole accountability that gets built around the relationships that are being established. But ultimately our goal is really to expand our ecosystem with this work and connect with more of those healthcare providers, making sure that we're intentional about the connection of relationship and not just a transaction that happens with the people that we're serving. Access to all of those additional resources that is being made available to us is just incredible. Just being able to track the data. I mean, being on this side with healthcare, we've been able to now use the electronic health record system. As a small community-based agency, those resources aren't available for software and for all of those different nuances that make it easier to track. But we have access to that now because we were fortunate as an agency to be able to contract with, you know, the insurance providers and now provide those services. But by and large, most of our agencies are not in that space. And so this gives an audience and an avenue for all of us that we're on that side, very passionate, but lack the capacity to make the connections. So I'm really excited about that. And ultimately, I think it creates that improved quality of life that all of us have been searching for our clients. So I'm very excited about this. And I'll be your greatest cheerleader, your greatest fan, but also your greatest critic if it doesn't work out the way we need it to from a community perspective, but knowing that it is a relationship. And so we're gonna go through the good, the bad, the ugly all together.
That's right.
Okay.
And so if you don't mind, Shawn, I have a quick question.
Yes.
What does it look like? Are both your clinicians and sort of folks in your organization that are more on the social service side of things engaging with the database on a daily basis, or with the platform, I should say?
Well, because we have a no wrong door policy, everyone in the agency has to be familiar in every division with how to access it. And so our team has grown from 7 to 27.
Oh, wow.
And so we're actively, and then when the marriage happened and we took a short pause, in the fall, I said, okay, what is this going to look like? And so our entire team will be trained so that any service provider, from our behavior coaches to our case managers to our clinicians that are there for primary or for counseling, will have access to the platform to immediately. And so then it's less steps.
That's great.
When you have to go back to the other team, just right there on their tablets.
And it's so exciting that you're a part of this, because you've really been on this integration journey with us for the
we
last
have been
decade.
on this
So
journey. Yes.
That's really neat. Okay, Andrew, you're going to talk a little bit about where things stand at a system level, right? In terms of where we're at today, what it looks like going forward, and some of the resources we have available, right?
Yes. So yeah, I'm going to talk about the CommunityCares program. And many of you may have already seen us present on this, or you've been to a roadshow. So you know that this program has really been through quite a journey. A year ago, we were on this stage talking about launching the program and calling it CommunityCares. And originally, so we started this journey in the summer of last year. In terms of, we started our pilot then. We started bringing organizations onto the platform that we were using at that time, NowPow, that Taylor mentioned. And you know, it's really been an amazing experience. We've met a lot of people throughout the state, and we really started to build some of those networks and see the value and connections of those CBO organizations, the way that they support the healthcare continuum and how critical they are to the care. And so that was a really good start for us. But then, you know, Unite Us joined the team, and now, so we took some time to kind of get back to the drawing board, and we're relaunching now. So on the Unite Us platform, we're relaunching the CommunityCares system, and we should be going live with that in probably November, by the end of November, and we'll talk a little bit more about that. I have the timeline here. But first, just kind of talk about our partners. Two of them are on the stage here. So the program, what makes this possible, everything that we're talking about on stage and what we're trying to do statewide, really is what Access has done. So Access is investment in social determinants of health and supporting this platform as a free statewide system that any organizations can adopt to address those social determinants of health. So you don't need to be connected to Access. You don't need to be serving the Access community to get the benefit of that. Oh, that's not good. So by Access supporting that, that's going to allow us to spread this platform throughout the entire state. And so we very much appreciate that. And I think that is going to be what really makes it successful over time. Another key part of this partnership is our partnership with Solari, who operates our 211 Arizona. So they have over 30,000 resources on their platform all throughout the state, most of them in sort of the Maricopa County area, but we'll be bringing on all of those resources onto the platform over the next 6 months. And we'll have a connection into that 211 database so that those resources will continue to update. So once organizations do join on the platform in November, and then 3 months after that and so on, there will be a large number of resources on there already. So it's not going to be one organization on there and then 2 and then 3 where you have this sort of slow build. So that partnership with Solari really is going to allow the platform to have what's already on Unite Us, plus everything we're bringing on. So it's going to provide a lot of value. Contexture, so we're rolling out the program, and Unite Us is, Taylor sort of highlighted all the work they've done throughout the entire country, and their experience and what they've done is really going to benefit this program. Bringing what they've done to do large-scale implementations and some of the ideas that they've brought to the table for us has already been really exciting, and I think we're starting to get in a good direction. So as we're relaunching, we have new partners, and we have a system that is going to be a lot more efficient. And so we're really excited to see organizations that are already on CommunityCares 1.0 version will be coming over to CommunityCares, the newer version, and we'll be relaunching for everybody. So our program goals, and we've talked a lot about these just in general as we've been going through these presentations, but the number one goal really is connecting our Arizona communities. So for social determinants of health, those of you out there who may be familiar, it's something that we have learned through research over the last couple of decades to be one of the most critical parts of someone's healthcare. So we know that research shows that about 80 to 90% of the modifiable contributors to a person's well-being are those social determinants of health. So it's not whether or not a person is able to find a doctor or get a medication. It's whether or not that person can get to the doctor, whether or not that person can afford the medication. Do they have insurance? Someone could come in and you can diagnose them with a chronic condition, but if that person doesn't have the resources, you can give them everything that they need. You can tell them they need to do this, they need to take this medication, they need to have this diet, but if they don't have the social resources and the infrastructure around them, the supports, the community, that person is going to just do the bare minimum of what they can. They're going to be focused on surviving day to day, and they're not going to be able to attend those appointments, and their conditions are going to get worse. And we know that in our healthcare system, it's hard to change that paradigm. But what we're trying to do with this platform is if we provide this system for free for all organizations throughout the state, and we can change the process of how we do that. So when people do come in to a physician or a community-based organization, they can ask pointed questions on this platform that will connect them to those resources in the community. So it's not pulling something out of a drawer. It's not relying on maybe the resources that you currently have, but you can really expand those resources and get connected to those resources that you currently have on this platform. So the hope is that by implementing this throughout the state and putting it into those practices, we change that process, and people are getting connected to those social determinants of health because they're connected and organizations know how to get to those resources. Because right now, they may just struggle with being able to identify what the need is and then what is the resource. So that's what CommunityCares, powered by Unite Us, will do. And then we hope to see improved health outcomes with the whole person care mindset, right? So looking at the whole person, not just, you have a heart condition and you have to take this medication, you have to follow this clinical protocol, but also you need to eat better, and we need to connect you to services where you can get that food at a cost that you can afford. Or we need to, you live in a food desert, so how are you going to get the healthy foods that you need in order to support your heart condition? So these are the types of conversations that we want to start to put into those clinical conversations. And in order to do that, we have to provide that platform. So that's what we have. And it's going to be a data-driven approach. So organizations will be able to look at, what are they doing? What is are we making a lot of referrals for a certain service? We can see how long organizations take to respond to referrals. You can see the organizations that you've referred to. It could really help inform business practices and inform sort of what we're doing, or maybe even identify where in the community we are lacking resources. And then of course, one of our key goals here is to help all of our healthcare organizations succeed in our DAP program, or in Access's DAP program. So the differential adjusted payment, for those of you that are not familiar, is an incentive program tied to this. So healthcare organizations that adopt the platform get an increase in payment on their claims.
Andrew, do you mind if I interject at this
Go
point?
for
Because
it.
I'm going to preempt the question that I know we're going to get. So obviously, as a Medicaid agency, we're able to offer incentive dollars to providers that are enrolled with our program for participation in CommunityCares. What are you doing, or we doing in partnership, I guess, to really incentivize engagement and participation of community-based organizations?
So we have 2 community-based organization incentive programs, and both of them are geared towards really trying to get past some of those initial barriers for those CBOs. I'll just come out of order here and jump to those. So this is our first program. This is our CBO Success Program. So for this, there's 3 milestones, and organizations, milestone 1 is required because you have to be connected to the platform to even be able to do 2 or 3, but you don't have to do them in these orders. So community-based organizations will get $2,000 simply for agreeing to connect to CommunityCares for up to for 3 years, and you have to opt in to receive referrals for at least 1 of your services. So you have to be on the platform as a CBO, and you have to opt in, and we'll give $2,000 for that. Then we will give an additional $3,000 for organizations that hit the usage metrics for 6 total months, so not consecutive. And this is a Unite Us measure on the platform that we're using, and it's responding to or resolving a referral within a period of time. So it's a percentage thing, so it's a 6 months. I don't want to get into it on stage because it gets kind of complicated, but we have advisors that will work with each CBO to make sure that they understand what those metrics are. And then the third milestone is we're going to give $5,000 to community-based organizations that will do a single sign-on integration with their platform. So if they have some type of system that they're using, if they're willing to integrate into that, we'll give that additional funding. The other program, this is coming soon, so this is not live yet. We do not have a policy and all of that yet, but we will be putting that together within the next couple months. It is the CBO Support Bank. So we've had multiple philanthropic funds and other supports that have provided additional funding to us, and we're going to have a bank of, and this dollar amount might change, but to what I know right now is about $1 million, close to it, for CBOs to access to basically join the platform. So whatever it is that they need, whether they need to, if it's a small community-based organization and they don't have computers or they have old computers, or they say, you know what, for our workflow to make this work, we need a tablet, we will purchase those tablets, computers, or whatever that infrastructure is. If it's a small organization in a rural community and maybe they don't have internet, we'll pay for internet for 2 years so that they can have, or we'll pay for internet for what we can in order to support that workflow. If an organization needs funding to support staffing, training, things like that, because we know staff time costs money in a CBO, every dollar counts. So we're going to offer funds for that as well. So we'll have a process for CBOs to basically submit and say, hey, this is what we want to do. Most of the time, we're just going to say yes, and we're going to do that and make sure that the goal is to get organizations, CBOs, to adopt the platform. We want them to push through some of those initial barriers of cost and change management, and we'll provide funds to get through that, and we'll be there to support you guys, support the CBOs throughout the whole process. I'm going to jump back a bit. Just to kind of talk about the CommunityCares, and I can go through this pretty quick because Taylor did a great job of talking about what Unite Us does. But one of the key things, of course, is the closed loop referrals with the outcome tracking, right? So you'll be able to use this platform to make those referrals into the community, and we see that closed loop, so you get that information of, was that service actually delivered? Because it has those screening tools on it, if you're not familiar with social terms of health, if you're a CBO and you say, we're not clinical, we don't understand this, well, it's a very simple screening tool, questions you ask somebody, and the system will report out, these are the needs that the person has. So you don't need to have that clinical experience. And the platform will do that for you. CommunityCares will do that for you. So you can use the platform as a resource guide. So some organizations are going to adopt the system and say, you know what, we don't want to make referrals on this. We don't want to accept referrals. It's just not how we do it, or we're not comfortable with that, and that's fine. There are certain incentives tied to that activity, but if they want to adopt the platform, they certainly can and use it just as a resource directory. So if you say, all right, I want to see the food banks in my community, and then this is a much more tailored resource directory for social determinants of health. We're going to be working with organizations to try to bring on your community partners. So if an organization joins and they have a large group of CBOs or healthcare partners, we'll get those names and we'll outreach and do our best to try to get them on the platform as well. And the CommunityCares on the Unite Us platform will allow for organizations to identify an administrator who can go on there and update the profile, update the information. So if you're a community-based organization, you can be much more assured that that information is going to be the most up-to-date information on the system. And the system, you can use this to find more resources, right? So as much as we may be embedded in our community, there might be a lot of community-based organizations and services in your community that you're not familiar with at all. And so when you when you're on this platform and you identify a food need, if they're on there too, you'll be able to expand that network and learn about the different services that are offered in your community.
Andrew, can I ask another question?
Absolutely.
So if you're an organization that's already doing this type of work and you're using a screening tool like Prepare, can you continue to use that with the Unite Us platform?
You can. So the Unite Us platform has a Prepare screening tool built into it. And I'll refer this over to Taylor.
Okay.
On,
Short answer is yes.
Yeah,
So
short answer,
we
yeah.
are screener agnostic.
Yeah.
Okay, great. And so I have a question for you, Taylor. Just curious, because Andrew was talking about if, in fact, you as an organization decide to join and participate and engage with the platform, if you're connected with other organizations, we can integrate them into the platform. I want to go back to something you talked a little bit about in your presentation, which was kind of around the curation of, or curating a network of really engaged providers and community-based organizations to ensure that we're kind of tailoring that network to be a network that's responsive when those referrals come in.
Yeah, so usually when we go into a state for the first time, we start with a baseline. Like, how long does it take organization A to make a referral to organization B, regardless if it's health, government, or community? How long does it take organization B to accept that referral? How long does it take them to actually provide those services? So there's an optimization component of making sure that the network is efficient and continuing to improve. But there's a lot of network effect where you engage with an early adopter, be it a community-based organization that has a ton of partners in the community that might not be on the platform. That could be a health system or a health plan or another agency. Really, the focus here is continuing to onboard. There's a go live and everyone can participate, but the network building never stops. And so you're continuing to bring on more and more organizations. So when we say community-wide, we really mean it. It's any organization that is touching or engaging with an individual that might need access to a broader network. We mentioned North Carolina. In North Carolina, we have barbershops on our platform. They're not providing, the hardline services, but you talk about an area where people congregate, they have trust, they're willing to open up and say, hey, I need access to, certain services. We don't want to miss that opportunity to then connect them to those services from a trusted partner. And so the network effect of bringing on more and more organizations and then continuing to optimize what are the best paths for individuals to connect to those services will continually change, and we'll continually to work and onboard those organizations as we go.
So you said flower shops?
Barbershops.
I can say firsthand, flower shops?
Barbershops.
Barbershops. I thought you said flower shops. I was going to say, I can say firsthand that flower shops are essential to my mental health. And my husband could tell you that, actually. Barbershops, that makes sense. Makes more sense than flower shops. Anyway, Andrew, I interrupted you.
But if there's any flower shops out there, we're willing to bring you in.
I interrupted you again, so go ahead.
I believe we had one CBO when we were doing 1.0 version, working with 211, that gave away eagle feathers was there. So,
Oh, yeah.
so there's
Yeah, there you go.
there's different services for
In the
everybody.
same vein.
So I noticed something, we've talked CBO, community-based organization, healthcare vernacular stuff. This has a very specific meaning. So we've talked about those incentives and what those are, but I do want to define that for you all. So when we say CBO or community-based organization, we're specifically talking about organizations that support those social determinants of health continuum, but they're not healthcare entities. So if your organization gets any billing, does any billing for healthcare services, that we are not considering that community-based organization. If there's any type of medical component to it, where it's not, we're not considering that community. If it's basically covered entity under HIPAA. So we're talking about food banks, organizations that are grant funded, and so that. But we do have incentives for those healthcare providers, and that is through the Access Differential Adjusted Payment Program. So that's why we did that carve out. So the incentives for those healthcare providers that are providing those community services that's through that DAP program incentive, and then these CBOs are for those entities that wouldn't qualify for that because they're not healthcare providers. And for the community-based organizations, we have those incentives, and then there's additional benefits to the platform. So they can use the Unitas platform, or the CommunityCares hosted on Unitas platform as their system. So if they don't have an EMR or they don't have a system already, they can use this one. Or if they do have one and maybe they're paying a certain amount for it every month, is there something that can CommunityCares meet all those needs? Can they use CommunityCares to track their members? And then that's free. So now they can save money and put that money towards something else. Another great benefit of this program for CBOs is they can access that reliable and up-to-date directory. So we were talking earlier about organizations relying on binders full of resources or whatever's programmed into the EMR, but that doesn't always get updated. We know our system changes, new organizations come all the time, hours change, resources change, benefits change. So this platform, CommunityCares, will offer a lot more up-to-date information. CBOs will be able to go in there and update their information. We'll be working closely with 211 to make sure that those updates are accurate and done consistently. And Unitas has a process for that I think is going to really make that a successful part of the program. Organizations will be able to update their information, including turning on or off receiving those electronic referrals. So if you're a community-based organization or healthcare provider and you are receiving referrals, but maybe things are difficult, staffing shortages, or we have a pandemic, you might want to turn off referrals for a period of time because you don't have resources to respond to them, so they have the opportunity to do that. And organizations will be able to pull, CBOs will be able to pull the data from the platform to make business decisions, learn what day of the week do we have the most people coming in, what organizations are making the most referrals to us. Maybe we need to reach out to them and build a stronger partnership because they're sending a lot of people our way. So there's a lot of great benefits to having a system like this, but we understand that this is something new and a lot to add. So that's why we have those incentive programs we talked about earlier, right? So knowing that this is going to really benefit them, how can we get through some of those initial challenges by offering funds and supporting that to get them adopted. So this is just a high-level timeline for our rollout. So I said we're live again. We are currently on wave 1, so there's organizations we've already been in touch with, and we're beginning to set up the onboarding. So we're mostly focusing on Maricopa County right now. However, because we did have our 1.0 rollout, we'll be working with all those organizations that are currently on the NowPow instance. We'll be working with all the organizations currently on Unitas, and anyone who's a part of our early adopter program will also be part of this first wave if they're ready. And then the organizations in Maricopa that we have connected with. So we'll be working through the next 3 months to bring those organizations live in November, late November, early December. And then it'll be a rolling onboarding. We'll still work with all those entities in the Maricopa region and that fit those criteria if they're not onboarded yet, but we'll start to move into the other regions of the state. And this is a strategy that's very different from what we did on our first rollout, and this is Unitas strategy that we're doing, and it makes a lot of sense because what we don't want is what I talked about earlier, someone to sign on day one and there not to be any resources on there. So when we bring organizations on, we'll be bringing them on in large chunks. So we'll have a decent amount or some of those 211 resources on there, and we'll bring on a bunch of organizations all at one time. So then we'll have a network that'll be operating, so those that are using it will have value day one, because that is really going to be critical. If you've rolled out new technology platforms at your organization before, and you know what it's like when staff open that and it's not useful day one, they just move on. So we want to try to make this as useful as possible day one, knowing that there's always going to be, those initial change management challenges. So if you're interested in joining, or if you have any questions about it, you can visit our website, communitycaresaz.org. There's an interest survey on there. The interest survey does ask some questions about your organization, gives us some details. So if you are interested, or if you're already part of the DAP program, please go to that website and fill out the interest survey. If you're thinking, we're definitely going to be part of that first wave, but you haven't filled out the interest survey, you might not be part of that first wave. So the interest survey is critical. Please go on there and fill that out. It gives Unite Us the information that they need to track everything, so they can determine which track they put the organization on to make a much more efficient onboarding. So if you are interested, or if you are enrolled in the DAP program, please go and do that if you have not already. So we'll use that information to set up our onboarding priorities. And there's going to be multiple documents, depending on your organization, that you'll need to sign. There's an agreement with us, pretty standard, and that is what affords the cost of the CommunityCares platform. And then there's some additional documents, depending on what type of organization you have, on Unite Us. Those are on the platform. Pretty straightforward, but we have support teams, advisors, myself, people at Unite Us that will assist if your organization has any questions with any of those forms or any concerns there. And it takes, what we've been told is about 6 to 12 weeks is a standard onboarding. And that's just going to depend on size, complexity, need, responsiveness, all that stuff. But generally, that's the time frame. And we have a booth in the room over there. So if you want to come over and ask questions or ask more about the program, feel free. So I'm Andrew Terech. I'm the Director of Social Determinants of Health. Clay is our manager right here. And then we've got Diana Kramer, who's our senior advisor. And you can reach out to any of us, email, phone, and we're here to answer your questions. And Clay and Diana are the champions of the onboarding process, so they're going to be leading those efforts with the Unite Us team. And so that's our program.
That's great. Quick question. You mentioned at the bottom of the second to last slide, you talked about the onboarding time being a little bit longer, I think, for entities that are willing to integrate the platform into their EHR. What do you anticipate, and maybe Taylor, this is a question for you based on your experience in other states as well, in terms of the percentage of participating providers that will ultimately be able to integrate the platform into their existing systems? I won't say just EHRs, because it might be other systems, right?
So it depends on the system that they have. For electronic health records, there are very few now that don't have the ability to do the integration. Same thing with care management platforms. Okay. Depending on what community organizations are leveraging, if they're leveraging something like Salesforce, that's an easier integration than maybe something that is a little bit homegrown. And so we'll work with each of those organizations to kind of figure out what the appropriate workflow is. But from a percentage perspective, when we look at healthcare, there are very few systems that we're unable to connect into.
Great, great. So I have another question for you, Taylor, and then I'm going to turn it over to you, Shawn. A different forms of the same question. So I know you work in a lot of states, so I'm really curious to know kind of what lessons learned, opportunities you think are, based on your experience, are things that we need to be thinking about in Arizona. And then I'm going to ask you, you talked about the good, I want to hear about the bad and the ugly next. So.
Yeah, I mean, I think the first thing that we see, our most successful networks across the country have healthcare, government, and community at the table. So we're starting off great here.
Good deal, good deal.
Because it really takes, not to be cliche, but it truly takes a village. There's not just government services, there's not just community-based organization services, it's everybody kind of working in concert and willing to kind of align to a similar vision to be successful. The other areas that we see for opportunity, and I'm going to highlight Gilbert here that we had a conversation on earlier, is the incentive programs that are put in place here. Think about those initially as operational. What we're seeing other states do is The future of social care, in my opinion, is where community-based organizations are reimbursed for the services that they provide, same way that we reimburse clinical organizations. And so what we see in North Carolina and in other states is they are including SDOH infrastructure as part of Medicaid dollars. The state of Arizona is doing that initially with housing, which is critically important, and it's a great first step. But I think over the next decade, $300 billion will be allocated back into the community. And the beauty of that $300 billion is those aren't new dollars. They already exist. It's just leveraging them a little bit more efficiently and effectively. And that goes across government, that goes across healthcare, and that goes across philanthropy. And so what we're seeing is once you have the infrastructure laid, then you have the ability to do a lot of cool things on top of it. And so what we see a lot of states and other organizations leverage is how do we all measure success? It's not just operationally, how quickly did someone receive services? Are we actually improving someone's health? Are we actually helping people step out of whatever situation that they're currently in? And how do we measure that? What we're doing in some of those other states is we call social need score. It's a predictive tool that helps us better identify folks, but then collectively measure, are we improving that person's overall health and well-being? It's a simple score from 0 to 99. Anybody above 60 probably has multiple social vulnerabilities. So are we addressing food? Are we addressing housing? Are we addressing some of the other social components outside of just clinical? And how do all of those organizations work together in concert to improve that individual or that family? And so what we're seeing is states doing is once the infrastructure is laid, they can get very narrow on the populations that they serve and very targeted in those interventions, both of measuring success, but where do I allocate dollars? How do I address some capacity constraints? And how do I bring social care to the same priority level as healthcare? There's tools that we bring to the table. Those tools are a virtual paperweight if organizations aren't leveraging them. And so again, it takes all of us to kind of come to the table and work together. We're going to find kinks, we're going to iron out those kinks, but there's a big opportunity, and I think what you all have done here in Arizona is set the stage where everybody's coming in together right out of the gate. And that very rarely happens, and it's super exciting because there's so much potential in that offering.
Yeah, and to your point, I think it's really about reinvesting the savings, right, that you're able to generate. Right. You all in this room, I'm sure you've heard our data points around housing, but we house about 2,500 members a year with rental subsidy dollars, right? When we looked at our 2020 data and the 2021 data just came in, I'm taking a look at it tomorrow with my team, but we saw 31% reduction in ED visits, 44% reduction in inpatient stays, and a savings of over $5,500 per member per month. And what's really exciting, and Dana alluded to this in the last panel, is CMS is finally recognizing the savings potential. And you know what I always say in front of audiences like this is, we're not going to have a conversation with an individual about a preventative care visit if they don't have a place to live. That's right. I mean, that's foundational, right? And so I'm really excited. We're on the precipice, we think, knock on wood, of CMS approval for our housing, our extended housing ask. And I think the data that we have has been really influential in that regard. So I hope more states opt to take advantage of some of the opportunity that's present right now. So I know I foreshadowed what I was going to ask, but I really appreciated your comments about this being a journey. It's not going to be easy. We know it is like a marriage. That's what you said to me before we got on the stage. It is. So we have commitment, and that means we're going to work through the good, bad, and the ugly. What are some of the hiccups maybe that you've seen or that you anticipate for your colleagues and peers as they start to take advantage of the platform?
I think Taylor spoke to it, just the devaluing of the work that was being done in the community-based sector prior to now. And I really want to hone in on the fact that Unitas recognized the value of what Zion was doing before we got into the health side of things. We've only been into the integrated health for a year now. But prior to that, all of our journey had been on the community-based side, and that lack of connectedness and lack of relationship with our government entities, with our healthcare providers, prevented us from being able to do the work to the magnitude that we wanted to. We didn't have the opportunity to look at the data the way that you do, but we saw the lives change. So we saw that mom who kept her children and they weren't placed in DCS custody because of the relationships that existed, so that family was able to stay connected. Or we saw that grandmother who was able to get the AC for her house so that her high blood pressure, her diabetes, all those other chronic diseases she was struggling with weren't impacted because we had the hottest summers we had seen. And so being able to be connected to Unite Us plugged all of our partners together, and they were all talking. So the simple things, the barbershops, the painters, the carpenters, all of those people that are part of a non-traditional network were able to come together and say, okay, I can paint that house, I can do that job, I can change that AC, I can get an AC donated. Those simple things that weren't necessarily measurable through data points, but the lives actually being changed. And so that was the most immediate thing that we recognized, and I think that will be true for most of our partners. But I think some of the challenges are going to be in the area of trust. When we really start to talk about the people that we're being served and that are most significantly impacted with the disparities, it's our communities of color. And we happen to be located, our campus happens to be located in South Phoenix, and so we have a great melting pot of everything you could imagine there. But we're about 70% Hispanic, historically a Black community, but healthcare was not a space that we focused on culturally. It was more about survival in our communities. And so those networks that got built organically now have access to a tool that's unfamiliar, and it's being presented to us by a source that's not necessarily trusted. And so I think it's going to take those of us who are at the table, who are experiencing it, who have seen the fruit of marrying with the two groups to say, you know what, come and be a part of this, try this out. And so you may have a lot of early adopters that say, we just want to see it as a guide and a resource. But you'll have those that are like Zion, where our innovation said, okay, our social service people aren't getting paid, so we're going to make them contractors under Zion as a healthcare provider. So they're case managers, they're coaches, they're all of these resources that we can reimburse for to actually build their infrastructure. So you'll see some innovation start to happen with those healthcare providers that are willing to do the work in that way. And so I think we'll get there. The marriage happened really, really fast for me, which was exciting. It was more like an arranged marriage. There was no courtship. It was just a suddenly. But it's working. And so kudos to the suddenly. I love the idea of ultimately healthcare, you know, will be compensated, community-based work will be compensated because the ultimate savings, we are seeing that. The way that we're able to leverage those dollars to hire more people is because I'm not having to spend as much doing crisis management, but it's more transformational work and not just transactional work that's happening.
And I think one thing to just add on to that, like trust is so critically important. You know, I can't tell you how many times we've gone into a community for the first time to kind of talk about the work we're doing, and you just get punched right in the nose. Because community-based organizations, there is trust that you have to build, and that takes time. And if you're unwilling to kind of stand there and take the fire and understand, you know, the issues that they might have with a network or their workflow or how they haven't felt appreciated, if you don't do that work, you're never going to get them. You're starting off the wrong foot. And I think one of the benefits of this partnership is that you can't just say, oh, we're going to fund this for a year. Because that's not a lot of time to build trust. Outside of this marriage, that, you know, just like that. But you have to give it time. And if you set that time horizon where, hey, if you just want to start off with a resource directory, that's fine, we're still going to be here whenever you're ready. And you just keep showing up, and you just keep showing up, and you just keep showing up. You have to, you know, let people come to the network, participate in the network when they're ready to do so. And that might not be right away, and that's also okay.
So true. Well, we really appreciate your stewardship, I have to say that. I'm curious, so in regard to, and then I'll go to questions because I see Morgan out there already ready at the microphone. But I'm curious, one of the things, I think the question we've had as a Medicaid agency, and we've heard differing things from differing folks. Do CBOs generally want to become Medicaid enrolled providers and bill for services, or do we need to think of a different way to financially support community-based organizations?
Grants are considered gravy. CBOs traditionally are nonprofit. That does not mean no money. That means we just can't keep the proceeds. They need to go back into programming. So the contractual process is complex. It is overwhelming. Our example is we've been in it for a year and we're just starting to get paid. Most CBOs can't afford to do that or don't understand the processes. So if we can have the learning curve lessened by having some trainings for how to engage, and then having maybe some hubs or experts that will do that. I don't consider us an expert. I think we got hit by all the trucks so that all of our partners don't have to. So I can tell you which ones to dodge and which ones to hop in to get you down the road faster. But some trainings in preparation, because I do think the contractual commitment brings a different level of accountability that has to be there, because passion does not equal capacity. So everyone that wants to do the work may not be good at it and might not be the right partner for it. So I think contractual commitment does add a level of accountability that should be there, but grants aren't sustainable. The relationships are what makes it more sustainable. For the pandemic being a perfect example, when things shut down, we didn't get to our doctors, we didn't get to our counselors, we couldn't get there to say what we needed. And it really put the burden on the community-based agencies that were able to keep our doors open to be able to be the bridge until we got to the other side. But that was next to impossible. But it created an opportunity for us to create a whole campus in South Phoenix, where agencies had been silos and in different spaces. A lot of them lost their infrastructure, didn't have a building anymore. But we have a campus that everyone could be housed on. And we were fortunate to be in that situation, but that created this opportunity. But I don't think that's the norm.
Yeah, it's something we've been thinking a lot about with the anticipation that CMS is going to approve this this housing waiver, which includes transitional housing. So we've had a number of non-traditional partners come to the table and say, we're ready. But to your very point, we need training, we need education, we need to understand how this process works, but we're excited about having a stable source of funding for the work that we've been doing historically, which is so important to the community. Okay, Morgan, I see you out there. We'll go to audience questions if you want to get us started.
All right, Jami, well, I jumped up here because I couldn't get anybody in this crowd to move for me yesterday. They just left me hanging on the stage.
I see.
So we've spent the last 2 days hearing about the different products and services that are coming out of the HIE, the evolution of the industry, Arizona health directives, registries, and now we're rounding it out with CommunityCares. While we've got you on the stage, I would love for you to share from your seat in the theater how you see all of this coming together to really weave together a national leading effort across the state, leveraging the HIE technology, and what's the vision that you're, the grand vision that you're executing against?
Are you asking me?
I am.
Yeah, I thought so. We are so fortunate in Arizona to have one HIE, and we've always seen Contexture, as a critical partner, and it made a lot of sense to us out of the gate when we started talking about a closed loop referral system to partner with Contexture. They house all of the invaluable clinical data that our providers access day in and day out, and we want providers equally to be accessing data about individuals' social service needs to give them a really kind of a whole person picture of what is going on in an individual's life. We talk often, Melissa and I do, to other states about the value of this partnership, and in particular extending this partnership to include work around social determinants of health. So we're certainly encouraging other states to form similar partnerships. In my mind, it just makes sense. And I'm hopeful that other states are sort of seeing the light as well. I don't know, Taylor, if you have any kind of inside knowledge given your work in other states.
Yeah, I mean, I think what we're also seeing, to your question to Shawn earlier, is this isn't just a Medicaid thing. This isn't just on Medicaid. Right. While that's usually a big budget line item for states, what we're seeing is there are other avenues to bring dollars to community-based organizations. We look at the healthcare industry in this country, $4 trillion, massive. Social services, $3.5 trillion. And again, a lot of that's not coming from Medicaid. There are ways and avenues to bring dollars to the community, but again, we need to kind of remove like single points of failure of, oh, this is Medicaid's problem, or this is the community needs to figure this out, or this is healthcare that needs to figure this out. It is a collective across multiple agencies, so that, again, everybody's working in concert. And that could be philanthropy, that could be grants, but ideally it's for recurring revenue for community-based organizations, so they have a little bit of margin to continue to innovate themselves as well, which historically they've been, under the umbrella of grants or other funding mechanisms that are time-bound and very restrictive, that meet really the reporting needs of the funder rather than what the community needs. And so I think we start to see some of the shifts within those funding angles. That's really where you start to move the needle. But putting in for the CMS waiver is such a massive first start, because then it starts to give other states the ability to be like, oh, maybe I can do that too. And CMS is now really starting to understand, wait a minute, maybe we should start funding more of these initiatives in other states, and it's a momentum thing that we see. And so again, I was talking earlier with someone who's just like, if people are willing to invest in social services or community-based organizations or community health workers or whatever it is, I don't care what it is, I want more and more to go into that, because that's where you start to shift the tide a little bit. And states are doing that in different ways. But again, it's not just on Medicaid anymore, it's across other agencies as well.
I really appreciate that. That's a big discussion point for Medicaid directors these days.
Mm-hmm.
What is Medicaid's role in really supporting financially work around social determinants of health? And I think what we go back to is we're working hard, just like providers are in every state, to kind of cobble together resources, tapping into resources at the Department of Housing, Department of Economic Security, Health Services in Arizona anyway. But the thing that needs to happen too, and I do appreciate CMS's recognition of the importance of this work, but we need to see that sort of level of collaboration across agencies at the federal level, so that they are combining their resources in a way that makes sense, prevents duplication, and ensures that the broader population outside of Medicaid enrollees are able to access these critical services and supports.
I think that beyond the government piece of it, it's an opportunity for the public-private partnership, because community reinvestment can happen from the business sector as well. I think one of the roles that you all could play, being the most complex partner at the table, is figuring out what system can work so that there is an opportunity for philanthropy to look differently, or for businesses to invest in the solutions, because ultimately the cost savings does come that way. And philanthropy can move from the bean counting and how many people did you serve in transactional work to how many solutions did you create so that your work is no longer needed 10 years from now doing the same thing.
So important. We have, and I think Jim Stringham in the last panel mentioned our expectation at the agency level that all of our health plans reinvest 6% of their profit back out into the community, which has been really valuable. Now other states are starting to look at that as a potential for bringing in some of that private sector funding as well. I think I see another person at the microphone up here.
Yeah, this question is for Andrew. So if an organization misses the Maricopa group and they wanted to join later on, are they going to be onboarded after you finish the other waves, or when can they?
So it'll be rolling. So organizations, so we'll start with that first group and try to get everyone we can there. But obviously there's going to still be additional organizations. So as those organizations are ready to join, we'll roll them into as part of that next regional group, and they'll just join from Maricopa to the degree that we have resources. At this point, I think we'll be okay. But just to level set, I'm sure there's a cap at some point of how many organizations we can onboard in a period of time. But we will try to bring everyone on in those different cohorts. So if they missed that original one, they'll just get on to the next one.
Cool. Thank you.
Yeah.
Thanks so much. Any other questions? I don't think we see any other questions. I have to leave, but, but thank you so much for joining us today. Great discussion, and thanks to my fellow panelists.